here so we can all learn how to be better and to talk about tips on improving and maybe some fashion choices. So let's start with the first case. 70-year-old male, 9-month history of vision loss. Unfortunately, he's lost vision in both eyes. And the red eye started with redness, elevated pressure, uncontrolled inflammation, and then developed bad enough glaucoma that he needed to develop a CRAO after getting intravitreal steroids. The left eye, unfortunately, the same sort of thing happened with elevated IOP, glaucoma surgery ×2, a CRVO with bevacizumab and steroid injections, and uncontrolled macular edema. He also has a history of non-Hodgkin's lymphoma, has been on chemotherapy. Light perception, 20/70, pressure of 4 and 12. Here's our first view into the right eye and into the left eye, and I'll show you guys here just the fluorescein angiography, just highlighting a pretty large area of non-perfusion, a significant amount of leakage, and a fair amount of macular non-perfusion in the left eye. So this is our story. We have this picture here, a 70-year-old bilateral progressive, over a year vision loss with a history of CRAO, CRVO, and glaucoma, which all started with inflammation. So I put it to my panel. When you see a picture like this and this kind of story, what else are you looking for? What kind of tips do you have here? So if I can start all the way at the end with Al. Al, when you look at this kind of case, what do you see, what do you think, and what should we be worried about? Al, oh, sorry. You're studying the picture really intently. I like it. That's what I did when we first got it.
So, I mean, the history of immunosuppression is extremely important, and the age of the patient, obviously. This is a widespread retinitis that, you know, you have to think of an infection. You have to think of something that is going to, you know, totally destroy the eye, which it already has done, and an infection that might be associated with elevated intraocular pressure.
Exactly. I think that point there of the infection with elevated intraocular pressure, and as you pointed out, the historical details of non-Hodgkin's lymphoma and his age, I think is really, really important. So, Phoebe, if I restate this now as bilateral pain uveitis with retinitis in a 70-year-old on immune suppression, how do you think of this case? This is no longer a CRAO case, CRVO case, it's now pain uveitis. What should we be worried about or thinking about in this scenario?
Yeah, obviously the viral retinitis agents such as CMV, HSV, VZV, in this partially immunosuppressed or immunosuppressed individual who's elderly, CMV would be probably tough on the differential, also VZV. So I would probably do a vitreous tap or an EC tap and try to get PCR.
Yeah, excellent. I think we had the exact same thought, and it turned out his EC tap was positive for CMV. We injected postgarnet, started antivirals. You can see here the antivirals are working. He gets an oral Valgan, but unfortunately a year later, his NLP in his right eye and 20/80 in his left eye. So Tom, what went wrong here? I mean, you know, we have a patient who has progressive vision loss, you know, CRAO, CRVO. At what point was it? Did we miss a diagnosis along the way? Did something else new develop? How could we have prevented this, do you think, from your perspective?
Well, I think the problem occurred right before you saw the patient. So I think there may have been areas of retinitis that were missed before when he was undergoing his vascular occlusives. I mean, it could be that those are unrelated incidents, but probably they were all occlusive vasculitis due to the CMV. So I think there might have been occlusive or missed. It's impossible to tell going backwards what it was at the time, but that's what's suggested.
I think that, you know, take-home message, if things are getting worse and you have an elderly patient with new inflammation, you know, I always put down, think medication, think about their systemic disease, and let's be really, really careful with local steroid injections, because unfortunately you can take an eye that's normal and unknowingly unmask an infectious agent. So we're going to move to our second case here. So this is a 27-year-old male, presents to the ER with several weeks history of decreased vision and pain, bilateral granulomatous anterior uveitis. He started on predacetate and has laboratory evaluation set. So he gets his laboratory evaluation, which shows an elevated CRP and ESR. Patients called weeks later for his results, and he said, well, you know, I ran out my drops. I want them refilled because they're helping, and he was told to follow up, and unfortunately didn't come back to about 3 months later. So his vision's now 2200. He has 3+ cell and 2+ haze. So here's a picture of his anterior chamber showing the massive amount of carotid precipitates, posterior synechii. You can get sort of a view into the back of his eye, but then you can see that there's a fair amount of haze, retinal vascular leakage that's occurring. So Lisa, let me ask you your thoughts. You have a person who has bilateral chronic pain uveitis, has a workup that looks like this. Are we done? Is it enough? Should I start the steroids? What do you think about this kind of workup, and how do you determine what to order in this kind of patient?
So this is something I talk with my fellows all the time. We got to make sure that it is not infectious before you even consider oral steroids. And you know, there's no quantiferin, there's no TB testing, there's no syphilis testing. And we know that those can have devastating consequences should we do periocular or intraocular steroids. So that, to me, this is not enough. We've got to make sure before we declare this is not infectious, an infectious organ.
All right, so we're going to try to work about for infection. So part of the way I do that is get a review system. So I ask him if he has any medical problems. He says none. Wait a minute, I had a history of tuberculosis. I had a positive PPD. I was on anti-TB meds, and I've had 60-pound weight loss over the past few months. Anything else? You know, well, the steroids help my rash, but now it's worse. Would you like to see my rash? Call up Tal Malvini. Come on over, bud. Let's see if you can look at this rash. And there is his back, his trunk, and his feet. Dr. Rao, when you see this, is there anything else this is besides one disease?
You know, I hate to shake my hand every time I see a patient with uveitis. So this is a good example. I think top on the list, when you do their soul, palm should be considered. I think syphilis would be top on the list.
Yeah, it's a high suspicion for syphilis. He also had a penile rash, which I didn't show you guys, and a long history of TB. So we weren't able to assay with this syphilis IgG. Jenna, can you help us out here? So when you get a test result in something like this, you're really suspicious of syphilis, and you get this kind of test result where it's not clear. What's happening in this kind of patient when the syphilis IgG or your syphilis test is kind of equivocal, or they say it's negative? Is it truly in this scenario?
Well, it used to be a prosone effect, that they had so much antibody that you just couldn't detect it. I think that that's less likely to occur right now. Uncertain what happened in this case, but you have 3 different types of tests. You have 2 treponema tests, you have 1 non-treponema test, and I think you should just keep going as you did until you get the positive that you need.
Exactly, I think that's important because sometimes there can be interfering substances that are produced and can actually negate this. So HIV positive starting on IV penicillin. So let's review this case. Was the skin rash new? Well, his original ER note said the patient was complaining of rash on his skin for a few weeks. The original ophthalmology note had no dilation. His first set of labs didn't include a syphilis test, and his review systems was documented as normal. So for the panels, and I'll go back the other way. So Dr. Rao, when you said, should we just go ahead and say that syphilis testing every uveitis patient? Do we have to argue about this anymore? Should there ever be a case of uveitis that does not have a syphilis test done?
Syphilis should be considered always in the differential diagnosis because it can manifest in any way. Anterior, intermediate, posterior, granulomatous, non-granulomatous, vasculitis, disc, and other features. So, at least in my practice, I routinely obtain serology for syphilis.
Okay, and for all of us, I think we're doing the treponema test. Has making the news. The New York Times just 2 days ago. STD cases rise to a record high, go us, and keeps going up and up each year. The bottom one shows you it does not matter where you live in the United States. It's becoming more and more common. So politics has nothing to do with syphilis and sexually transmitted disease. So we can make things worse by not looking, not thinking, and again, local steroids in an infectious case. Let's move to our next case, which is a 27-year-old female from the Ohio River Valley. Has a history of poor vision in her left eye for years. She was diagnosed with POHS, presumed ocular histoplasmosis syndrome, and inflammatory vascular membrane years ago. She was given injections, had no real improvement, and now has new vision loss in her left eye with photopsias. Her injections were restarted with anti-VEGF, and she was told she has end-stage POHS. So here's a view into her right eye and left eye, and you can see here's her OCT showing this outer retinal change, multifocal outer retinal change, no real intraretinal edema. And her fluorescein here, which shows us probably spots in both and some leakage, especially in the left eye, an ICG that shows you lots of dark spots, and a fundus autofluorescence. So, Lisa, this patient tells me, after getting all this testing, why you're imaging so much, every time I go to my doctor, so all I get is an OCT. And if you keep getting all these tests, I'm not coming back. So, you and I are in the Midwest. Is this presumed ocular histoplasmosis syndrome? Okay, she's not going to say it.
Yelled at.
No, don't get yelled at. So one day I will be brave enough to say that I don't think POHS exists in a big crowd, but today's not that day. So let's say that, with improved imaging, when you see someone like this, should we default to POHS? What should we do in these kind of scenarios where you have somebody maybe who's younger who has maybe a CNV?
So, I mean, for me, looking at this again, the new term, the multifocal choroiditis without uveitis is kind of more my go-to versus that of the POHS. And then treating it more as a non-infectious, because I haven't ever been able to really isolate the histoplasmosis. And even people who have not been in the Mississippi area have come with this diagnosis. So I think that's kind of difficult.
Tom,
what about PIC? I like the term PIC.
You like the term PIC? You're just going to make it more confusing and just add more terms. Okay, all right, I'm just asking. That's right. We're going to have your own term, Janet.
Well, I think the imaging is really suggested that she's having an overlay of mutes on top of multifocal choroiditis.
Correct.
So she's having the acute event, but the background is not POHS, one would assume.
Right, so she gets, of course, oral steroids. You can see here she gets better, and she was 2,400 when she started. This is her at 6 months. You can see the multifocal response. This is at 1 year, this is at 2 year, and she saw 20/20 at year 2. So
Neil, what do you think about OCTA in this?
Yeah, I don't, and she did have an OCTA, which was misinterpreted when we walked in because there was a projection artifact that made it look like CNV when there was no CNV. So again, imaging can be misinterpreted. You can get too much, but you can also not get enough where you don't have anything. So I think the important thing here is use your multimodal imaging in uveitis patients, especially when you can't describe or explain visual acuity. OCT is great, but remember you're going to miss things. These are normal OCTs with the associated angiograms, those fluorescein and ICG, that show you that you can see things on other modalities that we have to consider.
Okay, so then we're going to go to the next case.
Yeah.
Was she myopic?
She was like a -3, that's it. She wasn't too myopic. A 40-year-old female.
One more thing I'd like to say.
Hey, you're not going to let me finish.
I'm sorry. I feel strongly that type of case where she's lost vision in one eye and she's got good vision in the other eye,
Yes.
I think that chronic immunosuppression might be appropriate.
100% agree. We talked about it at length with her, and we wanted to start her on it. She was incredibly hesitant and fought me along the way. So we've been watching her quite carefully. She's not agreed to immune suppression, but I agree with you 100% in that case. So I have a 40-year-old female with second opinion. She has lost vision for the past few months. So this 40-year-old was told she had cataracts, and she had dropless cataract surgery. Just 2 weeks later, she still can't see, and now it's worse. I can't tell you what the femto setting was. I don't know if it was a multifocal, but I do know she got triamcinolone and moxie in both eyes. She's 20/50 and 25/100. Here's her view in her right eye and her left eye. And here's her OCT showing you this prominent thing in the left eye, specifically the subretinal space. Fluorescein showing you this area, lighting up in the left eye, and you're seeing some leakage in the right eye. And ICG really not showing you much else here. So Phoebe, I'm going to ask you, I have this 40-year-old female with bilateral posterior uveitis, subretinal lighting. Which mistake is it? Is it doing cataract surgery to a 40-year-old or giving triamcinolone in this eye? Which one is it? Do you have to think here?
I would say both.
Okay, both. We're going to go with that. What are you thinking when you see that kind of picture?
Yeah, most likely she had poor vision, not from the cataract, but from the subretinal lesion that she had. And you can see that it's a retinal just on that fundus image because the vessels and cells are not obliterated, so this is not a retinitis. You know, I think it gets mistaken sometimes for a retinitis and people think viral. So it's in the subretinal space, it's hyper-reflective, and I guess she's a little bit young, but I might start thinking masquerade malignancy, possibly.
Agreed. So we work her up for infections. We decided to do a biopsy, and you know, I was thinking, Al and I were just talking about this, should we actually do a subretinal biopsy in the of that macular lesion? Well, she started developing choroidal during the case, so I'm now staring at a choroidal and now looking at this subretinal lesion right next to the fovea. Al, would you advise me to go in there and take this out?
No, I think that would be pleasant.
Yeah, that's what I said. I said, you know, let's not make things worse. Let's just see if we can get a diagnosis. So she ended up being positive for B-cell lymphoma. She got an LP, which was negative, and she started local therapy. I'm happy to say that she actually did really, really well. Remember that a clear lens will not lead to 2500 vision in a 40-year-old. This is her 3 months later. This is her at a year. This is her 1 year, 20/30 in both eyes. So vitrectomy, this also happens when you do vitrectomy for floaters. Make sure you're paying attention to what's going on with her patient. This is a patient who had a vitrectomy for floaters and actually had non-Hodgkin's lymphoma, B-cell lymphoma in the eye, which was misdiagnosed. So I'm going to end with one last case. A 50-year-old male referred for chronic uveitis. His kid, the patient's kids go to school, the referring doc's kids. This guy's a great guy. I was told that 4 times on the phone. 4-month history of pain, uveitis, unresponsive to steroids. He's hand motion 20/60. That's what his eye looks like. And you can see there's this yellowish lesions in the left eye. His B scan shows a retinal detachment, dense vitritis. He's worse on steroids. And I asked him if we can shake hands. Unlike Dr. Rao, I will shake hands. And he shows us this. Tom, what is this, man?
Well, the rash suggests the possibility of something disseminated. I mean, of course, they could be unrelated.
Yeah.
Since you're presenting it like this, you know, I think you have to think about potential infectious causes. Is there anything else in the district?
Well, he's a pharmacist and he shoots up drugs. Those are track marks. That's what we call them. Yeah. So tap and inject. He's positive for Canada. He's admitted. He actually ended up having vegetations on his heart. We actually saved this guy's life by figuring out what this guy had because he was on his way to something bad. So always remember endophthalmitis. Certainly elderly patients, IV drug use, yes, your neighbor can be an IV drug user, depending on your neighborhood, and always consider it. And this gets to the, don't be bashful when you're talking uveitis, ask the uncomfortable questions. Do you use drugs? What kind of sexual activity? Tell me about ulcers and rashes. And wait, who did you vote for exactly? I don't know if I want to know that. So in summary, to improve our outcomes, reduce common mistakes, avoid local steroids, ask questions, do a complete exam, always reaching the truth, and sometimes the young ones can learn. This is my family, probably not from me. So thank you to the panel, a great job, and thank you to the uveitis service.